Hello everyone, welcome to the ACO Reach 2.0 webinar. I'm Amara Rashid, your moderator and host for the session today. Before we start the session, let's take a moment to introduce our expert speakers. Joining us today, we have Gurpinder Singh, who is our technical project manager at Privia. He has expertise in machine learning and healthcare. He has diverse work background, including roles in technical project management, business development, sales, and has been leading the organizations that are managing multiple BBC contracts like ACO Reach to success. Our second speaker is Dr. Shannon Decker. She's the principal at BBC One and has more than 20 years experience in healthcare and most recently led teams in risk, quality, data, and analytics, telehealth, COVID response, and delegation compliance. Of her more than 20 years of experience in healthcare, 15 include working with risk adjustment, quality, and Medicare. We are thrilled to have such a knowledgeable thought leader guide us through today's discussion. Now, before we begin this session, a few housekeeping items for you guys. If you have any technical issues during the webinar, please use the chat function to reach out to our support team. We'll be happy to help you. We encourage you to ask questions throughout the session using the question and answer feature. We'll do our best to address them during the Q&A segment towards the end of the session. One more thing, this webinar is being recorded and the recording will be made available to all the registered participants after the session ends. Now let's get started with our first speaker, Gurpinder Singh, who will walk us through the program basics, key learnings from his experience of REACH Year 1, and the potential implications of the new updates to the program. Gurpinder, the virtual stage is all yours.
Thank you for the kind words, Mara. I'm going to begin the session. Can we please move to the ACO Reach program slide? So talking about the basic ACO Reach program, we are currently in the first performance year of the ACO Reach program, that is year 2023. And the current year ends on the last day of 2023, that would be 30th of December. Currently in this program, we have 132 participants who have opted for various tracks, including global or professional. And the participants are indeed required to have a health equity plan for ACO Reach. And the new model not only pushes for the health equity, but also pushes for the capitations. So the CMS is moving from fee for service to the capitation in the ACO Reach program. And we already have done a whole webinar on the ACO Reach program. So if anybody wants to know about it, they can review the whole ACO Reach program webinar we did. Moving on, if we talk about a typical ACO profile, typical ACO consists of multiple providers, and each of the provider take care of multiple patients. Now, when we talk about the management of the program, in a typical ACO, we get the data feed from multiple sources. Now, these sources can be your EHRs like Epic, Cerner, Meditech, NextGen, and so forth. But apart from these, we also get the information from the HIEs, the Health Information Exchanges. And the HIEs usually share the information in the form of an ADT feed, while the EHR share this information usually either in SIU format or using the flat files. Now, in addition with these, we also get the CC left data or the claims data directly from the CMS. These data streams, they change on weekly basis or even monthly or sometimes quarterly basis. So sometimes what we have experienced with our clients that they move from one EMR to another EMR. Sometimes they opt for new HIEs. So this is an ongoing process. Now, if we talk about the key learnings from our year 1, there are a few of the learnings. So we are doing ACO Reach for multiple clients. And what we have learned, we would like to share that today with all of you. So the first thing we realized that the data consolidation part. In order to have a complete picture of what's going on, you need to make sure that you are getting the data from all the possible sources about the patient. If you're a patient, you definitely get the EHR data that your patient is coming to visit you. But in the ACO, the patient could be going out of network to a different hospital, which is usually not covered by our EHR. So HIEs do come in handy in that context. We definitely get the data via CCLF or claims file, but claims file usually have a lag of a month or so. So in order to do the complete analysis, this was our learning that we need to make sure that we get data from multiple sources as soon as possible to take the required action. The second learning we had was the leakage, or what we call out of network utilization. Now, a lot of our patients they usually go out of network. And by out of network, what we mean here is the providers who are not part of your own ACO. The ACO Reach allows the provider who are Medicare beneficiaries to visit any provider that they would like to. They are not restricted to go to any specific provider. Thus, a lot of these patients go to any other provider that causes the leakage for an ACO. And we implemented some measures to make sure that we minimize this leakage. We'll be talking about it in more detail. Next part is tracking and managing the expenditures. The first part of managing the expenditure is to track your expenditure. And in order to track, it all gets related. We need to make sure that we are getting data from all the sources. And once we have the data, we can track all the expenditure and manage those expenditure. One of the examples, if I would like to share with you all, could be of if you look at your ACO population and you realize that, hey, in our region, patients are mostly suffering from this particular DRG, and we need to take further care of it. Now, you need to implement some measures internally or on the operation side to take care of these expenditures. The next part is adding and retaining new beneficiaries. This has been a really key factor. Out of 130 odd ACO who opted for it, a lot of them were on the edge. For example, for a standard operant, you need to have 5,000 beneficiaries. And if you have less than that, CMS is going to ask you to reach up to the 5,000 mark. So how do you add and retain new beneficiaries? One of the measures that we implemented is if we get the data from all the sources, we can flag the Medicare beneficiaries who are eligible for ACO Reach for you. For example, we already know what are the eligibility criteria for an ACO Reach beneficiary. An example could be they should be a Medicare beneficiary. They shouldn't have Medicare as primary, I should say. They should not have Medicare Advantage. They should be part of your own county. They should be US citizens or residents. So based upon the data we have, what we did was we flagged them. And the last learning was the EDI. EDI plays a key role. So EDI stands for Area Deprivation Index, which is a key factor for ACO Reach. Not only you have to submit an health equity report to CMS, but also this affects your total amount. And we'll be talking about this in the coming slides as well. Moving on, talking about the ACO Reach overhaul for performance year 2024. CMS have recently made some new changes to the 2024 performance year, starting from 1st January 2024. Now, the historic shift in the normalized risk score using older risk score models V22 and V24 may be significantly different from shifts observed using the new blending of the V28 risk model. We recently did a whole webinar on this, and you can also access this. We will be sharing the link with you for the detailed V28 HCC risk model discussion. The risk scores for all the benchmark years will be calculated using the same blend of risk score models that is used for the performance year. Moving on towards the 1% coding intensity factor cap, or what we call CIF, for performance year of 2024. As ACO Reach ACOs continue to mature and improve the coding accuracy among the assigned population, the possibility of a material CIF has also increased. By introducing this 1% CIF cap for performance year 2024, CMS is limiting the negative impact that CIF can have participating ACOs in 2024. The CIF is also one of the key source of benchmark uncertainty. So this change will make ACO Reach benchmarks more predictable. Now, talking about some new rules that the CMS implemented, for beneficiary alignment. As I mentioned earlier this year, the beneficiary alignment, uh, the minimum alignment you needed to have for a new entrant was 5,000. For the performance year 2025, they have reduced it to 4,000. But going forward, they have to maintain the minimum of 5,000. Even for the high risk needs population ACO, CMS has already reduced it from 1,200 to 1,000. But for the standard entrants, it's going to be the same, which was 5,000. Now, talking about the retrospective current adjustment or RTA dampening in excess of plus minus of 4%. There will be three symmetric RTA corridors, plus minus 0 to 4%, plus minus 4 to 8%, and greater than plus minus 8% with REACH ACOs, where they will accept the 100%, 50%, and 0% responsibility for the respective corridors. While this adjustment helps stabilize REACH ACO benchmarks in case of sizable RTAs, our expectation is that it is unlikely the RTA will exceed 4% in the future performance years, as the market continues to recover and stabilize after the lingering impacts of COVID-19 on the healthcare trends. Now, what I mentioned in the previous slide about the health equity. So moving on to the next slide, we talk about the health equity changes. This is one of the key changes that CMS has brought in for the performance year 2024. Right now, CMS is calculating the HEBA or health equity benchmark adjustment score based upon two factors. The two factors are your national base ADI, and the second is your dual Medicare or Medicaid status. But for the performance year 2024, they're going to change it to three different factors. Each of them have equal weightage. The new factor that they have added is the state-based ADI in deciles. For more information on this, or in order to calculate the HEBA scores, CMS has provided us a source which is called Neighborhood Atlas. It is provided by the Wisconsin University website, and it can be accessed by anybody. And these scores are not calculated based upon the the zip code or county level. They are very precise based upon the specific zone. So you need a particular street address in order to pull out the ADI for the national based index and as well as the state decile. Once you calculate that, you can have a score, and based upon that, CMS will make the adjustments to the benchmark. Now, CMS has not changed a lot in this, but now they will be providing, same as before, 30% per beneficiary per month in the top decile, but they'll also provide $20 per beneficiary per month in the second decile, and then $10 per beneficiary per month in the third decile. And in the bottom three deciles, they will subtract $10 from your benchmark per beneficiary per month. And the rest of deciles will have no impact whatsoever on the benchmark. There have been some changes in the high needs population. So moving on to the next slide, in addition to the current criteria for alignment of high risk needs population, CMS has also included with at least 90 Medicare covered days of home health services utilization, or at least 45 Medicare covered days in skilled nursing facility within previous 12 months. If you are currently part of an high needs ACO, or you are thinking about it, this change will make a significant difference that you need to consider. Moving on, talking about the reach for success. I'm going to hand it over to our expert here, Dr. Shannon Decker, who will be talking more about it. Dr. Decker, if you can please unmute yourself.
Thank you. Sorry about that. I was just remarking, thank you for taking us through all that great information and making it much easier to understand some of the changes. So now I'm going to take you through and just talk about some of the best practices that we've observed. So next slide. So one of the things that is important is to make sure that you move beyond clinical data. And what I mean by this is you really need to understand your patients and their needs. There's a greater emphasis, right, on getting to know that patient and creating stickiness with you. One of the things, as Gurpinder had shared with us, there's a difference between voluntary and claims alignment. And even when patients voluntarily align with you, they still have to have a visit with you within that next 12 months once they align. Otherwise, right, you run the risk of losing that patient to another ACO or being aligned elsewhere. But the thing to really remember too there is it's really important. The whole model is about managing your patients. And so having that information on them beyond the clinical data will be important. You want to make sure that you collect and operationalize your social determinants of health data. And so think about training your office to do motivational interviewing. One of the things that I've noticed is that a lot of offices or even health plans will send out surveys that members can complete when they're trying to collect this data. And what happens is you get a lot of check boxes. And I don't really think that that data then comes to us in an actionable form. And so, what I would recommend is training staff within your office to have those conversations. It not only builds connections with those patients, but it also really allows you to get deep and create that connection with them, right? When it comes to wanting to encourage them to get the visits, to do the preventative screenings that are also important in this work. We also need to make sure that we're investing time in this personal in these personal connections. It's a lot less costly than risking having the patient go to, say, an emergency room from their care. You want them to call you first. And then, to the point about operationalizing, I think this is a great opportunity once you determine where the patient needs are to connect into those community based organizations. I think that praxis, this idea of giving back to one's community in which you reside, is so important. And so making those connections with those community-based organizations or CBOs in order to connect your patients to the care that they might need beyond the clinical, right? Those social needs would be important. And then make sure that you're monitoring your programs. And I know I'll talk a little bit more about methods that you can employ to do that, but don't assume just because you've built something or put it in motion that people will automatically join in. So humanity is complex and ever changing, and so by checking in with your populations, and doing that research, looking for those multiple data points is really important. Checking in on your initiatives, surveys, and like the CAP survey, I don't think are enough to really inform you, nor are they as timely. And so getting out of the community, again, connecting with those CBOs where you've developed partnerships, getting to know your patients, and just asking them, right, as to whether or not your programs are succeeding. Next slide. And so just building on some of those ideas. So one here, developing health equity plans and focusing on specific demographics or diseases are key aspects of ACO Reach. The thing that I would recommend here is remembering that one size doesn't fit all. And so what works for one community, one demographic, a chronic condition may not work for all. And I can give you an example of having led programs in the state of California. Southern California, totally different environment. We would have health fairs where we would invite patients to come in and get their preventative screenings. There's a lot more parking in Southern California than there is, say, when I was working in Northern California, where you had a lot of public transportation that patients could take. And so the way in which we set things up were totally different. Be thinking about that when you're doing your outreach with your health equity plans. If you're doing, say, I know a lot of groups choose to do webinars on cooking for their diabetic population. Make sure that your patients have that technology. Or is it a group that would prefer to come together, right? And meet with people and socialize. What does that look like? And so be thinking about those nuances and how it might apply to your population. On point number two here, looking at the health equity plan as a living document, one that changes as providers and ACOs learn more about the population that they serve. Can't emphasize that enough, right? You want to evaluate and revise as needed. So just as you wouldn't expect treatment, right, of patients to stay the same, their conditions, right, life changes over time. The health equity plan should too. Pay attention also to who your membership is because it may change. I've been a part of a lot of plans where, to no fault of the provider or the plan, people move, lives change, and so your membership may change too. And so what worked for you a year ago, 3 years ago, a month ago, right, may be different than what works for you today. And so be in tune with that, of how things may be changing and how people show up, right, to take care of their health. On point number three here, most plans will require additional editing and refinement as more data is captured and care gaps are identified. Absolutely. I think that we are just on the cusp of this ocean of data that's available to us and bringing it in. And I think the Privia tool is a great tool for that. But look at your data to inform. A recommendation that I would make to folks, a lot of times people think, oh, data and research, and they're off put by that because it seems like it's really scary. But I recommend doing a quasi experimental study. And it simply is you do a pre test and a post test. How are you doing before with a particular population? You do your intervention, right? Whatever it is that you're doing, maybe it's those diabetic cooking classes or providing health fairs around the neighborhood or whatever it is that you choose for your population, and then looking at the impact that you had. But it's really important, right, to think about what you want the end goal to be. And then what I recommend doing is doing something that's called task analysis. So think about, where your population is, where you want them to get through or get to, what the ultimate goal is, and then break it down into pieces. Task analyze that. What are the steps that you need to take to get there? And then monitor along the way. And that's how, a great way for building plans. And then consider too, like I said, those multiple data points. I think it's essential. It's not enough, right, to just look at quantitative data. And I know a lot of folks, they tend to give credence to those numbers. But as a researcher and a professor at a couple of different universities, I can tell you that when we advise students and they're setting up their research models, that they choose the research strategy that best matches what they're trying to accomplish. We're working with humanity here, very complex. These are social experiments, if you will, or social research that we're engaged in. And so while quantitative may be great for larger populations when you're trying to answer maybe more simple questions, I think qualitative is probably a better way to go here. And so make sure that you're, again, doing that motivational interviewing, hearing from your patients, how things are working from them. You may even do what's called a mixed method and combine those. But don't just look at the numbers. Dig deep, look underneath those numbers, and really understand, what's getting you there. On number four, use a logic model. There's lots of different models that you can use. I like something that's called the SIP model. It's where you look at context, input, product, and process. Um, Really what it advises you to do is make sure that you're looking at all the pieces that go into the program that you're devising. So it's not just about where you started and where you got to. It's about looking at how does it affect all the different pieces. And what's great about that model is it allows you to be scalable, flexible, and then because you're focusing on pieces like stakeholder and budget and making sure the program that you built is sustainable, like we said, that health equity plan is going to change over time, and you want to be nimble and be able to change, right, as your population changes and as their needs change. And so it's a great model that you can use to continually monitor and improve on what you're doing. Uh, but to make it a little bit more simple, one of the things that you can do is pull out a component of that. And a lot of folks are really familiar with what we call Plan, Do, Study, Act. And so, think about what you're going to do, study it, act upon it, and then again, just making sure that you're coming back and evaluating it. Being a leader for more than 20 years in healthcare, there's been a lot of programs that I've put out there, and I always make sure to come back around and don't assume that what worked for me last year, or like I said, even a month ago, is going to continue to work. And so check in with those programs, make sure that they're still working for you. And then that perfect plan, that number five, it's going to be making sure to connect with your stakeholders, your patients, those community based organizations, right? Working with the different folks in your office, using those multiple data points. So, again, not just the number, but don't be afraid to get in there and get that qualitative information. And then finally, implementing this continuous improvement cycle. So, not setting something in motion and assuming that all will be well. It's going to be really important to continue to check in and see how things are going. And so that takes us to next slide. So technology, we can't do this work and do it well without technology. It's so important. And so to number one here, data analysis, think about your reporting needs and think about the multiple levels, right, in which you can devise reports. There's lots of options out there, not just looking at, what diagnoses were captured or what care gaps were closed. You have the way to bring that information together and slice it and dice it in a way where you can understand, what's working with the population. Maybe, there are challenges with transportation in a particular area. Maybe you have a higher propensity of diabetes in your demographic. And so being able to not only identify these individual data points, but then bring them back together allows you to take that data and tell a story, right? And understand your patients, which is number two, that population health in aggregate. So just as you're looking at that individual patient, so important to ACO Reach is to really understand your population as a whole and how to manage it. There's going to be some patients that are going to require more care than others. And so you want to think about how your strategy might be different for those particular populations. But it's going to be very difficult to see that if you're focusing on that individual patient and not looking at the population as well. So it's that micro, macro, view and going back and forth. The other thing is this care coordination, right? So making sure patients are getting the care they need at the most appropriate site. Examples of this might be making sure that you have an after hours line so that patients, right, if something happens in the middle of the night and they need assistance, they don't have to go to the ER to get it, right? And then they can come see you. You have same day appointments that they can come to the office rather than going into a weekend maybe without the medications that they need. And so building in those programs that make sure that, and that's just one element, but making sure that patients are getting the care that they need. That they're getting it at the right site, right? That they're seeing the right people, so they're getting into the specialists that they need to, and when they don't, are all really important. Quality and risk management. This is a great opportunity for our physicians to participate in risk-bearing programs. You're going to need to make sure that you see those patients. You cannot, not see them, not only from an alignment perspective, but in order to establish what their disease burden is, you need to be able to collect those diagnoses and be treating them. And a large part of that too is preventative care. So in order to be successful at ACO Reach, I really think about it as it's this moment where we understand who our patients are and what their needs are. And if we can interrupt what we would expect the typical trajectory to be in healthcare, which we know in a lot of ways hasn't been good, right? Patients can't get the referrals that they need. They don't know where to go. There's lots of social determinants of health, transportation, health literacy that exacerbate their conditions. If we can change that trajectory, we have the ability, right, to manage a very sick population at a lower cost. It's really what it's about. So encouraging patients to get their quality screenings, making sure to capture their risk. And then those point of care insights, I think, are so important. So making sure we all have really busy schedules, patients too, and we have limited time when you're in the office seeing them. Try to maximize that time while you have them in those moments to make sure that, again, they're getting their quality screenings, to make sure that you're capturing their burden of illness to the highest specificity that you can. Next slide. And then finally, just to wrap up from my perspective, what's needed for success, number one here. So remember that ACO Reach allows for you to choose between professional or global risk. You may not be ready for global risk. And I know a lot of groups chose that in that first year because it provides the biggest gain, but it also requires a lot of management. And so professional risk would allow you to get your feet wet, if you will, to make sure that you have the programs in place and that you can do the basic foundational work that really needs to be done in order to be successful at ACO Reach before taking on greater risk through global risk. And then, number two here, know your patient population. And I know that, we've talked about that, but think about also too, who are the providers, who are the physicians that are part of your ACO network? Are they doing what you need them to do? And if not, maybe they don't belong as part of your network, right? You might find other providers that are better serving your patients. And so it's really important to continually evaluate that and whether or not they're advancing your goals. Three, choose the right technology partner. Make sure that your technology partner, like I said, technology, or excuse me, ACO Reach is complex. Humanity, right? The human condition, healthcare, all complex. You need someone that can bring all the various data feeds together, standardize that data, and then, like I was saying earlier, provide it at the point of care that you can make the right decision in that limited time that you have. Because again, we're all so busy. Number four, look at the total cost of care. It's not about capturing just risk or doing the quality screenings or getting good scores on your CAP survey for ACO Reach, but also too making sure again that patients aren't ending up in the hospital. One of the quality measures that's monitored is there's two actually. There's one that's readmission rate, so making sure that patients don't end up back in the hospital. And then the other is those patients with chronic conditions, we know what the typical trajectory is. If we can avoid, right, them ending up in the ER and with an inpatient stay because we treated them in the office first, right, those are the things that are important. And so making sure that, again, you're managing patients to the least amount of intervention as possible, if you will, or at those earlier parts of that disease trajectory and not letting them get exacerbated and end up in the hospital with an inpatient stay when it's not, it could be avoided. And then also know too, look at whole person care, all the different things that go into who that patient is. And then, again, going back to and making sure that, ACO Reach, it aligns with the goals of value-based care. So aiming to shift the focus, not just from reactive healthcare, which I think is, that's the paradigm that we've operated in now for years, is reacting. A patient shows up with symptoms and, we provide care. But how can we be proactive? How can we prevent them, right, from getting diabetes, from requiring insulin, from, slipping into needing dialysis, say, for their chronic kidney disease? And so to the extent that we can do that is really important. So, I think Privia has a great tool. I'm going to go ahead and turn it back over to Gurpinder to talk to you about some of the benefits of the tool and how that might be used to help you in your plan for success as I've laid out here for you today. Gurpinder?
Thank you, Dr. Decker. And really appreciate your detailed insights here based upon the real life scenarios and the experience that you have had over the last so many years. Now, talking about the partner with Privia for success. So what can Privia do for you? What Privia has been doing so far? From the last 15 to 16 odd years, Privia has been at the forefront of developing advanced AI-driven solutions. We not only enable payers, providers, and hospital systems, but also public health agencies to manage multiple value-based programs across all available datasets and settings. We have had clients who are managing like 8 different ACO programs with us. Privia system is built on a unified data model. Our model, that is called CareSpace, leverages the power of data and the AI to derive the real value from the data. CareSpace builds a longitudinal record, and we spoke about this in detail at the beginning of the webinar as well. The patient record we get from so many different sources. It can be claims, clinical, HIEs, EDTs. What Privia does is it creates a dynamic longitudinal record. The longitudinal record helps us do the analysis more accurately and in a better way as well. At the heart of CareSpace, we have our AI engine, Soliton, that does all the magic with this data and derive highly relevant clinical actionable insights that helps us automate workflows and processes. CareSpace is engineered to deliver whole person care and presents a true picture of every patient at every step of their patient management. It seamlessly presents all the information at the point of care right within the system. And as we spoke about earlier, CareSpace streamlines the transition to V28 by factoring in both models and presenting relevant diagnosis codes to the providers. This ensures the alignment between the organization goals and the clinical goals. Moving on to the next slide, are CareSpace modules. The beauty of our platform is that each and every module is built within the system. There is no third party involved that gives us the complete control over our system. And this also gives us the edge to help meet the varying needs of different organizations. We deliver a disciplined infrastructure that uses a microservice-based architecture, and any module or capability can be activated for any client at any point in time based upon their need. Since we are managing so many programs for so many clients, our system is so vast that more often than not, we already have the solution to the existing problems. CareSpace is a full service platform that provides the ability from data management to care management to care coordination, even the risk management and risk certification. We also help you take care of the quality aspect, the point of care integration, and the patient engagement via apps and portals. Talking about the next slide would be our success story. CareSpace has served as a key enabler to promote Prime Healthcare Initiative that was improving and promoting the social determinants of health at a system level, allowing the Prime team to connect with community resources and track patients' well-being in the real time. And this led to Prime Healthcare winning the 20th John M. Eisenberg Patient Safety and Quality Awards at the national level. This has enabled the Prime team, like I mentioned, to connect with community resource partners and track the patient's well-being in the real time. After the discharge, the community partner shared patients' progress via the portal, thus establishing a bi-directional exchange of patients' updates and transparency between the Prime hospitals and their community partners. And we hope that we can do that for a lot more of our clients. Talking about the results we have achieved for multiple clients. These are some of the numbers that we would like to share. And one specifically, I would like to mention that over the period of time, we have improved the HCC capture by tremendous 290%. We have also have been 98% accurate in extracting the HCC codes from the physician notes through NLP. Our AI engine is really doing the job for us and helping our clients as well. We have been 90% accurate in predicting the high cost cohorts through machine learning based predictive modeling. And we don't just use one machine learning model. We have trained our various models and we compared them. After comparing them, we have fed them the data from over years and years of data that has helped us reach this stage. That's pretty much it from my side. If anybody have any questions and answers. Anything, Dr. Decker, you would like to include? Umar, over to you for the Q&A.
All right, thank you so much, Gurpinder and Dr. Decker. It was really insightful. I'll move on to our question and answer session now. Just a quick reminder for you guys, don't forget to drop your question in the Q&A panel if you haven't yet. Mm, just give me a moment before we begin the session.
You know, Amara, while you're bringing that up, I just want to remind folks too that there is a cap, a 3% cap on risk score improvement year over year. And one of the things that I've heard from a lot of folks is that, well, you know, why should I focus on more if the benchmark is already set or I can only get to a certain level of improvement? And I think one of the things that was mentioned by Gurpinder and about, you know, having the ability to capture risk and what's so important is that, you know, you shouldn't limit yourself. In fact, I can tell you just looking at the performance of a lot of groups that the 3% in most cases has not been reached. And that same limit, at least for this year, is not on those high risk patients, especially our patients, you know, that are receiving benefits. And so, to the extent that you can capture, it's all about accuracy. And then also, too, you know, you're in it for the long game with ACO Reach. And so, wanting to make sure that you're recapturing those conditions year over year. And so, to the extent that you can get that complete data in, I think it's really important.
Thank you so much for that, Dr. Decker. I think you've checked all the boxes today. Let's just move on to the questions now. Okay, so I have a so this first question is directed to Dr. Decker, and it says like MSSP, REACH will eventually be a race to the bottom with ever-changing tougher benchmarks. What's the strategy to stay on top of that?
I think, you know, what we laid out to be ahead of the curve and doing everything you can to tap into your patients. Um, you know, I tend not to, when I launch programs, I tend not to think about what can get me. You know, not that you're not being circumspect, right, and thinking about all the ways that, you know, things could potentially go wrong. But I think rather that, you know, when you're running a race, you're not looking behind you, you're looking ahead. And things will continue to evolve. I mean, look at already we had challenges. ACO Reach was just launched this year. We had challenges. CMS noticed those, and I'm really impressed. I'll give a nod to CMS. I don't know if they're on the line, but I'm really impressed with the rapidity in which they're responding to things. And, you know, the fact that they came out on August 18th and changed, right, knowing that there was a problem or a challenge with beneficiary alignment and that we were struggling with that and some of the other components. I think that, you know, that you run your best race. You don't think about, you know, the folks around you or what's behind you, but you run your best race. And so, you know, that means again, if the challenge, right, isn't one with capturing burden of illness, and you know that's number one, so making sure to record all those conditions. Preventative care, right? To the extent we know that there's a typical trajectory, say with diabetes or congestive heart failure, if you can get folks to get the preventative screenings and implement interventions through your health equity plans that prevent them, right, from getting to that place where we know they've gotten, and healthcare hasn't been optimal for a lot of years. And so I think that there's a lot of room for us to improve. So I wouldn't necessarily worry about the benchmark catching up with you. I think that, like I said, you need to run your race and you need to do the best job that you can do with capturing the risk of those patients, trying to prevent them from living out that risk that we typically expect through quality programs, through managing total cost of care. There's a lot of work we haven't done well for a lot of years, including in Medicare Advantage. So I think that there's a lot of opportunity.
Okay, great. Let's move on to our next question. Mm. Okay, so the next question is we are struggling with gaining beneficiaries and especially surprised by more than expected attrition in aligned populations. Do you think it's wise to move providers from other Medicare programs to REACH to bolster the number of attributed beneficiaries for the coming performance years?
I have an opinion, but Gurpinder, I want to give you an opportunity to speak to that too. I don't know if there's anything you want to add.
Sure, Dr. Decker. In fact, I was waiting for you to answer that and then would share my opinion. But thank you for giving me this opportunity. One of the key factors that we need to keep in mind here is ACO Reach trumps a lot of programs. If you have a BPCI program or CGR program in a region, and if the beneficiary is aligned to an ACO, essentially the BPCI and CGR program is not valid, right? So at the end of the day, the beneficiary can be aligned to only one Medicare program. And since ACO Reach trumps a lot of programs, it does indeed make sense to bring that patient over to the ACO Reach. Because in a region, if you want, somebody else will take the responsibility of care of that patient. So my 2 cents on this, and definitely you should bring in the beneficiaries. But also you need to take a look at other factors as well. You cannot do that blindly. You need to take care of the status of that patient. You need to take care at the previous total cost of care of that patient, the DHCC opportunities that you have with the patient. So there are a lot of other factors that need to be included along with that. And it's way more complex than what we can discuss at the moment. But in short, if the patient is comparatively healthy, I would definitely move it to the ACO Reach program. That's my 2 cents on that.
And I would say an excellent points. So thank you for that. And I would just add on and say that I wouldn't necessarily shy away though either from those patients, right? That are sicker patients. They need care too, and I think that they provide even to some extent. Um, Opportunities to better manage them. And I know that there's also too that ADI bonus that's available on those patients. I definitely think that, so we know that CMS, at least what we've been told, is that the expectation is that patients will be in some risk adjusting model by 2030. I think that ACO Reach provides a great opportunity from moving away from the traditional fee for service. And again, what I tend to think is more reactive, that reactive paradigm into something that's more proactive that can be managed. One of the things that I would take a look at, and you may not be ready for this, or you need the technology, right, to be able to assess where your providers are, but do take a look at not only the patients, but look at the physicians that you're adding into your network. Make sure that you have the right mix. I've been a part of other ACOs, not reach based, where there was a propensity of specialty in that mix, and it drove up total cost of care and created some challenges. Take a look at not only who your provider mix is and whether or not they're appropriate. Like we said, it needs to be appropriate to the patient population. So the providers that you have as part of your ACO Reach network, are they appropriate for your patient population? But then also too, are they doing the things that you need them to do? Do they provide after hour services, right? Do they provide maybe Saturday hours? Are they doing that motivational interviewing? Are they connected with the CBOs? These are all types of programs that you can develop to help you be successful. Is there a way to make sure that their patients, when it's appropriate, aren't going to the ER? They actually are schooled and educated on what urgent cares are in the area. These are all things that we've been doing in Medicare Advantage for years that are also important strategies when it comes to ACO Reach. And so, I understand that alignment is a challenge, but I would take a look at, all those other components that are important to your success.
Okay, let's look at the third question now. Um, so the kind of technology platform you guys talked about requires a big investment. Most ACOs don't have big budgets for that. Is there a way out for them?
I'll jump in here. I think that, don't think about, I always think of the old adage that, how do you eat an elephant? And you don't swallow them whole, right? It's a bite at a time. And I know that, Persivia for one, but there are platforms out there. There's ways in which you can phase things in, maybe looking at a pilot, right? I know that I'll just say, having worked with Persivia for a while, that there are opportunities to creatively structure some of those contracts, so that it doesn't feel like it's such an expensive investment. And I think that what you'll find that an investment today, just like anything, right? An investment today will have huge payoffs in the end. It's just making sure to find the right partner to work with. And one of the things, and I can speak about this platform, is that you have physicians. I always think of it like minding the gap. You have physicians that are helping devise, right, how the algorithms are, what needs to be part of this system. And so you're always going to be forward thinking, which is important. You want a partner that can scale with you, that's going to be sustainable, aware of what the changes are, how to handle the various data feeds that are coming in, being able to standardize that information and put it in a way that not only makes sense from the technology side, but like I said, makes sense from the that clinical side as well. And I think it's really important to have good clinicians on the development team of any platform that you're considering, that can mind that gap, if you will, between the technology and the clinical.
Thanks, Dr. Decker. That makes a lot of sense. So the last question, can you elaborate a bit more on the logic model you talked about? How can we use them within our team?
Sure. It actually is about an hour seminar that I typically do. But if you look up SIP, it was first proposed by someone named Stufflebean, but it talks about looking at your context. So what is when you look at a program, you don't do it within a vacuum, right? You look at the communities in which you're launching that program, and what are all the contributors, what sets up the context, right, of what you're trying to do, and then inputs. Who is a part of the work that you're doing. And so take a look at those that are contributing to any program that you may have launched. Look at the processes. Are there processes within your office that you can change or maybe would help you be better at this work? Maybe it's involving the office manager to go through the list of your ACO attributed patients, making sure that they're aligned with you, that they're getting in, like I mentioned, if someone's voluntarily aligned with you, they still have to come in and see you, or they risk being, torn away and attributed elsewhere. And so going through that list of patients, making sure that they're getting in to see you, having your MA help you room that patient, flag the chart when you know that certain screenings maybe are due or needed for that patient, capturing, particular conditions, getting those recapture lists, which are all data insights that can be provided by Persivia. That might be an opportunity. So again, context, input, processes, and then looking at programs too. Those health equity programs that you have, are they designed in a way that is appropriate, for the population that you're serving? I'm going to be publishing a separate webinar just taking folks through that SIP model. But I think, really just to simplify it, those are ways in which you can expand. If you focus just on that one piece of process, and that's simply looking at that, what a lot of people are familiar with, that plan, do, study, act life cycle, I think is important. You simply make a plan, right? You implement it, you study it, look at the data. Again, don't assume that just because you set something in motion, that it's going to work. And then act is making those interventions, right, when they're needed. So if something isn't working or getting the results that maybe it got 3 months ago, that you need to tweak some, that you can do that. Or it may be going back and then becoming, right, more multifaceted by including other parts of, say, that SIP model, right? Maybe you want to address the inputs or the context. or some other component as part of that process. I think and I'll just leave at this point, just to try to keep it simple because you've got a lot of hard work to do. But really think about, what is the goal that you want to achieve? What does that look like? And then go back to the beginning. So think of the end in mind. It's a linear model. Think of the end in mind, go back to the beginning, and then that task analysis is so important. We don't get up off of our couch, right, as a couch potato and go run a marathon. There are steps that we have to take to get there. The same thing is going to be true of being successful with ACO Reach and implementing any health equity plan or anything else that we're doing. Think about where do you want people to be and what are the steps that you need to devise and those checkpoints along the way of how you're going to get there. And for each of those components, right, each of those tasks, you want to have that plan, do, study, act mindset in mind as you're going. And anytime that they don't get to that task, right, or that milestone along the way, uh, those are components or areas where you can go back and look and see how can I improve or are there ways in which I can make things better.
Okay, interesting. So I think these were all the questions I had from the attendees today. So we have come to the end of our session. It was really insightful and engaging. Thanks a lot, Dr. Decker and Gurpinder. Are there any final comments you guys want to make before I wrap up?
Gurpinder, you want to lead?
Sure, Dr. Nikesh. So one thing I have learned over the period of time is this is a new program, and Dr. Decker has also emphasized on that. This year, we all made a lot of, I wouldn't say mistakes because those were the learning curves to this program. This was year one. Going forward, we are getting more mature. Even CMS is making some changes, and I'm expecting a couple of other changes to come as well, maybe in coming couple of years before this becomes a core program. But there have been few learning curves. Yeah, if we have made mistakes on the way, just don't get disheartened. And that's what our clients have taught us as well, right? Take this as a learning curve, and we are getting into a new year. And based upon you have done enough research, I'm pretty sure if you're part of the ECA program. So uh, take one day at a time with the ACO Reach program. That would be my insight.
I love that feedback, and I'm a hopeless optimist. I know, and I love I feel like what challenges us helps us grow, and I think it's a really great opportunity for our physicians to be able to, explore this model and to do well for themselves, right? And then also to, I know folks went to medical school to do right by patients, right, and to help improve lives. And I think that, through these programs that we can do that and physicians can be compensated, better compensated, right, for the work that you're providing. You're providing so much care for some of these patients that are our sicker patients, and you should be rewarded for that, and for the hard work that you're putting in. Agree, don't be scared, but, be thoughtful. And I would consider professional risk to assess your abilities and then think about what it would take to move to global risk. And of course, you have Privia and their tools to help you, and other consultants and me as a consultant to help you as well navigate the space.